Welcome everyone, and thank you so much for joining us. We're going to go ahead and get started. On behalf of NHF, welcome to Inhibitor Treatments Now in the Future. Next slide, please. We want to welcome you. My name is Natalia Winberry, Manager of Education at the National Hemophilia Foundation. And again, our session today is Inhibitor Treatments Now in the Future with our speaker, Dr. Tyler Buckner. Next slide, please. We would also like to thank the generosity of our 2021 sponsors of the Inhibitor Education Series, Genentech, Hemophilia Alliance, Hemobiologics, Takeda, Santa Fe Genzyme, and Novo Nordisk. Next slide, please. And now I want to give you a couple of tips about getting the most out of this session. Please use the chat box to write in questions or comments. The speaker will try to respond to as many as possible at the end of the session. Please be sure to give additional feedback at the end by filling out the evaluation. This presentation will be recorded and will be available to watch online. Next slide, please. And now we have one speaker disclosure. And now I would love to turn to our wonderful session, Inhibitor Treatments Now in the Future. At this time, I would like to take a moment to introduce Dr. Tyler Buckner. Tyler Buckner is a pediatric and adult hematologist at the University of Colorado Hemophilia and Thrombosis Center, where he provides care to individuals with bleeding and clotting disorders. He also helps to lead a number of clinical research studies that aim to improve outcomes for patients with bleeding disorders, particularly those living with chronic pain. Dr. Buckner has been involved with NHF inhibitor summits since 2016. And now I would love to turn over now the presentation to Dr. Buckner. Welcome.
Thank you very much, Natalia. Wave if you can hear me. Good, excellent. All right, well, thanks very much to NHF and Inhibitor Summits for allowing me to participate again this year. This is one of my favorite meetings, and while virtual is not my favorite format, I am glad to be here and have a chance to talk with you today. This is an overview of the talk for today. We will talk about current treatment options for people with inhibitors, and we're specifically focused in this talk on hemophilia A and B inhibitors. We'll also talk about other other treatment options, including non-bypass therapy, non-replacement therapies, and some of those that are under development. And then we'll end up with some mention of gene therapy and the different approaches being taken to help people with inhibitors. So in terms of how we approach management of hemophilia with inhibitors, there's three real main goals that we have in terms of the inhibitor themselves. First is to treat bleeds. So when bleeds occur, we need to get that to stop. We'd refer to that as an acute bleeding event. Second, we would like to prevent bleeds when that's appropriate and when that's possible. And then third is to try to get rid of the inhibitor if we can. So the first step is to treat bleeds and be prepared to treat bleeds. These treatments are all likely familiar to individuals who have inhibitors, and they often revolve around the use of a bypass agent. There are currently two products that do this. One is recombinant activated factor VII. Brand names would include Novo-7 and a newer medicine, 7-Fact. Both of those work in the same way, or very similar ways. And then APCC, which stands for activated prothrombin complex concentrate, also known by the brand name of FIBA. For the APCC, we don't always use that for factor IX inhibitors in treatment, but it certainly can be used in factor VIII inhibitors. Sometimes, in some cases, bleeding can be treated with factor itself, so factor VIII or factor IX, if the inhibitor level is low enough. Sometimes we can give enough factor in order to overcome a low titer inhibitor. And then we also use antifibrinolytic medications. In some cases, those medicines include aminocaproic acid and tranexamic acid, also known as Amicar and Lysteta. So those are the, in general, the treatments that we use for treating bleeding. For preventing bleeds, we would refer to this as prophylaxis, as many of you are familiar. There is since the last time I gave a talk like this to this group, Emicizumab was not commercially available. It was still in its clinical trial back in 2017. That's a bispecific antibody. We'll spend some time talking about the bispecifics. And so we'll get to that in a little later, but that is certainly an option for prevention of bleeds or for prophylaxis in people with inhibitors. There are also regimens for using recombinant factor VII for prophylaxis, as well as APCC. And so different patients may be on those medications for preventing bleeds. Again, for low-level inhibitors, we sometimes view giving factor VIII or factor IX, more often factor VIII, as prophylaxis as well. And we'll mention that when we talk about ITI, which is the next slide. So in terms of getting rid of the inhibitor, the approach differs a bit depending on where you're kind of coming from. If you have severe hemophilia, so that means that your factor, the amount of factor you make is less than 1% of the normal level of factor, either factor VIII or factor IX, we often use immune tolerance induction to get rid of the inhibitor. These regimens involve regular, repeated exposure to either factor VIII or factor IX, whichever, whether you have hemophilia A or B. What this is aiming to do is to teach the body's immune system to see that protein as not foreign anymore. So the part of why inhibitors develop in someone with severe hemophilia is because the body hasn't learned that factor VIII or factor IX is okay and is responding with the immune system to get rid of it. And so we want to teach the immune system that it's okay and that factor should be viewed as a protein that we tolerate. That's the tolerance part of immune tolerance. That process can take weeks, months, and even years in some cases, and involves a lot of infusions of factor, often 3 times a week or every other day, and sometimes daily or even twice daily, depending on the regimen that's being used. And so immune tolerance induction for severe hemophilia. If you have mild or moderate hemophilia, the approach is often different. So if your level of factor is between 1 and 40%, then you may be using an immune suppressive or immune modulating regimen rather than immune tolerance induction. And that's related to the mechanisms of why these inhibitors develop in someone with mild or moderate hemophilia, why you would choose an immune suppressive regimen. And so this would be more along the lines of giving a medication like rituximab, which inhibits the production of antibodies in the body. So all that being said, there are some mild and especially moderate patients in whom we attempt ITI. It is also worth noting that if you have an inhibitor that either doesn't go away or when you are not able to use ITI, simply avoiding being exposed to factor VIII or factor IX can over time lead to the inhibitor level coming down kind of on its own. The body will just stop making the antibody very slowly over time. That's not really the same as tolerance, which by that I mean if your inhibitor level goes down and down and down because you haven't had any factor VIII for 6 years, the next time you get factor VIII, it's likely that the inhibitor will come back up. The body will remember that it doesn't like that protein and begin making antibody again. That we call anamnescence in immunological terms, and is certainly something that we would expect to see after a long period of not being exposed to factor. Doesn't always happen, but it can in some cases. So what are the limitations? What are the big challenges with living with a hemophilia and an inhibitor? There are limitations to our treatment, and one of the big ones is that ITI is not always successful. Only in 2/3 of people with factor VIII inhibitors, and really only in 1/4 of people with factor IX inhibitors will ITI be successful. And so if it's not, we say that ITI has failed and we can't get the inhibitor to go away. Another limitation is that both APCC and recombinant factor VII don't really work as well as factor for stopping bleeding. The prophylaxis regimens with those drugs are not typically as successful, meaning there are more bleeds than we would like to see, particularly when we compare that to someone who does not have an inhibitor and is on factor VIII or factor IX prophylaxis. They make surgical management more difficult. Especially in the case of factor VII, the dosing regimens are much more frequent, often using factor VII every 2 hours right after surgery. And then overall, logistically, that presents a lot of challenges for people. If you have to be tied down to a FIBA infusion that takes a long time, or factor VII infusions that have to be done quite a bit more frequently than factor VIII or factor IX. There's also no reliable way to monitor either of these medications. You can't just check a factor VII level after you give factor VII and expect to get a meaningful result. And so we're left kind of just trying to figure out if someone's bleeding has stopped or not, based on symptoms and how they're doing. There is also a thrombosis risk or blood clot risk whenever we're using medicines to help stop bleeding, which also limits our options in certain situations. So there are plenty of limitations to treatments that really the community's been working for years and years to try to make this treatment better, easier, more effective, and safer. So what are our specific goals that we would like to see as we move forward? So with ITI, we certainly would like to have a higher success rate with fewer bleeds during ITI. And really, if we could make it easier and still have better success, that would be one of the holy grails, is to get that inhibitor to go away, but to avoid the need for daily infusions of factor. We also, of course, want better, more effective treatment. So kind of the opposite of everything on the previous slide. We want bleeds to be more easily prevented. We want treatment that's better. We want easier time around surgery, improved logistics, and the ability to monitor with labs. And then overall, first and foremost, we certainly want treatment that's safe. So what are some alternatives? We'll talk about the non-replacement therapies. That involves the factor VIII mimetics, which you're familiar with, at least one of those, as well as a couple of rebalancing therapies, which we'll dive into as well. So first, the factor VIII mimetics. I think of this as hiring a substitute. So you've got somebody that is on the job but isn't able to do their job. That's the factor, and because of the inhibitor. And so we hire someone else to substitute for that missing factor's function. So these mimetics for factor VIII do the job of factor VIII, but they don't look like factor VIII. The body doesn't recognize them as a factor VIII in terms of the inhibitor and how that functions. So the inhibitor antibody doesn't hook on to these drugs and inhibit them the same way that it does factor VIII. So they can work even if you have an inhibitor. which is the whole point. So why is that? How can we do that? So this is factor VIII here in purple, and its job is to grab factor IX and factor X and pull them together so that they're essentially close enough together that factor IX can then activate factor X and clotting can then continue. So it turns out that the distance between factors 9 and 10 when factor VIII is holding them is the same as the distance between the arm of an antibody. So antibodies are shaped like a Y, and these arms are the right distance apart so that if you make one arm stick to factor IX and one arm stick to factor X, then that antibody can pull those two factors together so that, again, factor IX can activate 10 and clotting can proceed from there and continue. So that's how Emicizumab and the other factor VIII mimetics works, by pulling 9 and 10 together. And it is an antibody, just like an inhibitor is an antibody. And the fact that the structure is different is why the factor inhibitor does not inhibit Emicizumab. So where are we with Emi these days? So there are multiple clinical trials, which I'll show you an overview on the next slide. Many of those are completed. There are a number of trials that are ongoing as we continue to collect information about people's experience with Emicizumab. All the clinical trials that I'll show you all kind of added up to eventual approval for use by the FDA and the EMA in Europe for use in people with hemophilia A. So if you have an inhibitor, Emicizumab has been approved for use for almost 4 years now, since November of 17. And then it was approved for use in people who don't have inhibitors, so all people with hemophilia A, in October of 2018. So a little bit less time in that group of people, but it can be used even if you don't have an inhibitor, in much the same way as it is used in people with inhibitors. So here's an overview of the clinical trials. You may have heard of the VIII studies that have been run and are being run for this drug, Emicizumab. VIII-1 was the first study done, which is handy since they numbered it in order. This was a study in people with inhibitors, so over the age of 12. So 12 or older, people with inhibitors got weekly Emicizumab. VIII-2 was the study in people with inhibitors under the age of 12 years. So this was the pediatric study, and they tested 3 different dosing regimens in that group of patients. VIII-3 is the study in people without inhibitors in adolescents and adults. And then VIII-4 is both and is really looking at the monthly or every 4-week dosing regimen. There are a number of other VIII studies. I believe we're up to 7 now, and these are looking at different groups in different settings. For instance, VIII-6 is the study of Emicizumab for mild and moderate hemophilia A. In these first 4 trials, there were 401 subjects across all 4 of them. The citations for those studies' main results are listed down here if anyone's interested. But that's kind of the structure of how they've looked at using this medicine in different groups of people. So some practical aspects of Emicizumab: it is given as an injection under the skin. It is not an IV medication. Dosing, as I mentioned, can be done every 1, 2, or 4 weeks. The important thing to remember is that bleeding has to be treated with something other than Emi. So Emi it cannot be used to treat a new or an acute bleed. It only is there to help prevent bleeds, but when bleeding happens, you still need treatment. And so if you have an active inhibitor at the time you get a bleed, then you need to go back to use the bypass agent that works best for you. Or if you have a low titer inhibitor, you could potentially use factor VIII for treating a bleed. But just remember that Emi is not used to treat acute bleeding. That'll be a theme for all of these alternative therapies that we're talking about. What did we see in the clinical trials, and why were these medicines approved? As you might imagine, there was a low and even a decreased rate of bleeding. It depends on what you compare to. If you compare Emicizumab to no treatment or to on-demand treatment, the bleeding was lower in that situation. And this is true across all the trials, regardless of inhibitor status, so whether you have an inhibitor or not. For people without inhibitors, Emi is really more along the lines of comparable to effective factor prophylaxis. So what I tell my patients is that if you are on factor VIII prophy and you only have one bleed a year, Emi is likely to give you similar results, maybe a little bit less bleeding, but that was not definitively proven, and certainly doesn't, that reflects my clinical experience, is that it'll be about the same as very effective factor prophylaxis. But if your factor prophylaxis, whether it's factor VII or factor VIII, if it's not very effective, then Emi is likely to be better than that for most people. There also overall see very few side effects, both in the clinical trials and in real life, I would say. The main thing to know about is that during the inhibitor study in VIII, there were some blood clots that developed. So kind of clots that we are used to seeing, like a clot in the lungs or in the leg veins, but also a new kind of clot that we did not expect to see with this medication called thrombotic microangiopathy, or TMA. And in those subjects that develop, in those studies that developed those clots, it was found that they occurred when they were receiving treatment for bleeds with high dose APCC. And so at that point, we learned to avoid using APCCs in people on Emi, and that has led to a great reduction, if not elimination, of that problem. This medication can be used in certain circumstances, but it has to be done when it's carefully monitored by a hematologist. So we generally just avoid APCC if you're taking Emicizumab. Notably, the Institute for Clinical and Economic Review, or ICER, did a report on Emicizumab and people who have inhibitors to evaluate whether that medication was cost effective. And they found that very convincingly in that situation, Emi was cost effective. So usually when you find a medication that works better than the previous option, it's also more expensive, and you have to weigh these. Are the benefits, do they justify the new expense? In Emicizumab's case, however, it not only worked better for people with inhibitors compared to the prior treatments, it was also less expensive compared to factor VII prophylaxis for specifically. And so that's an unusual situation for us in medicine, to find ourselves to have a treatment that's both better, more effective, and less expensive. Some of the numbers that they looked at from the VIII study to support that effectiveness statement. So if you compare Emicizumab to no prophylaxis, so this is on-demand treatment with factor VII or APCC, you see that the joint bleeds, we'll just focus on that, and on-demand regimens were around 6.7. With Emicizumab, that number was less than 1 per year, which is a very big difference, and actually clinically significant, and something that people obviously would notice, to go from a bleed every 8 weeks or so to really only once a year in a joint. If you compare Emicizumab to prophylaxis with a bypass agent, so factor VII most often, but also APCC, you see that a number of treated bleeds also goes down from about 16 to 3 after half a year, and then after a full year of Emi, down to even 2, which is again a significant decrease. And then for the VIII study, so for kids, we also saw low numbers of treated joint bleeds in those patients, the 23 patients that they analyzed in that study. So effective when compared to prior options for treatment. So in real life, we have now had almost 4 years of experience in the clinic with this medicine. There are multiple studies that are looking at real life outcomes and how it works outside of a clinical trial. Many of those have been reported. They're very similar kind of effectiveness and safety results to the clinical trials, would be my assessment. And a lot of those studies are ongoing. Our clinical experience has grown over those years as well. And we see that by and large, again, these are effective treatments if you have an inhibitor and appear to be safe. The effectiveness is not across the board. I would say that we perhaps would expect at the beginning that everybody would do really great. But it's actually turned out that there are a handful of people that just don't seem to respond as well to IMI. And we don't understand that right now, exactly why that is, or what makes it less or more likely that someone will do better on IMI. We have had a handful of patients in my clinic who have decided to switch back and go away from IMI for various reasons, but most often because it just didn't seem to be working as well. It does appear, again, largely to be safe as long as we're avoiding APCC, and that again is very actively being monitored and talked about all the time to given the lesson of the unexpected clots that were seen in that initial trial. We're all keen to make sure we monitor for any safety issues moving forward. So there are still unanswered questions, and these are the same questions that I talked about 4 years ago. We do have some sense of how to answer them. So what dose of emicizumab works the best, and how often does it need to be given? In terms of, do you choose the 1 week regimen every 2 weeks or every 4 weeks? And in the clinic anyway, that's still based on what my patient that I'm talking with prefers. If they prefer to do it more or less often, then those regimens appear to be equivalent in terms of how effective they are for preventing bleeding. Do we need to adjust factor doses or bypassing agent doses for bleeds or surgeries other than avoiding APCC? I would say that by and large, we don't adjust for major surgeries. Perhaps we reduce the duration or how long you need to be on factor after a surgery, but not by much, particularly after a major surgery like a knee replacement or an abdominal surgery. I have not changed my approach very much. Now that is also being looked at pretty closely because not everybody, as you might imagine, agrees with everybody on how best to do that. Complications long-term, we haven't seen any yet that I'm aware of. And then what impact does IMI have on how you do your ITI, if you're going to continue or start ITI for a new inhibitor? That is under investigation. It's a very interesting question that we're hoping some of the studies that are ongoing will try to answer. Can you use a lower dose? Can you get it less often and still eventually achieve immune tolerance while you're controlling bleeding with emicizumab? We don't know the answer. We hope to soon. It is also worth knowing that there are second generation mimetics now, so those are being developed. One of the examples is a drug called VIII, that's its current name, and that is out there. It's being, the clinical trials are working to get open if they're not already open. I don't know if patients have been enrolled or not. I think they have. But this is an active area, and hopefully these drugs will offer some advantage compared to the first generation mimetic, which is emicizumab, and we'll see even better results with no change or reduction in safety. So we're waiting for those kinds of studies to be done. So let's now we'll go back and include our patients with factor IX inhibitors as well. Because these rebalancing therapies are applicable in those patients, unlike emicizumab and the mimetics, which are only for factor VIII. So we all have natural anticoagulants that our bodies make. Those include protein C, protein S, antithrombin, something called tissue factor pathway inhibitor, which will abbreviate TFPI. Those proteins in general, when they're active in the body, increase bleeding, but they're balanced with our procoagulant proteins like factor 8, factor 9, etc. So one question is, if we reduce the effects of these anticoagulants, can we reduce bleeding that way? So what is meant by that? How do we, what are we talking about? So in the ideal situation, the systems that lead to bleeding and the systems that lead to clotting are in balance, and we don't have abnormal bleeding or abnormal clotting where you don't want it to be happening. I think of this as a car that we're driving and we want just the right speed. And so the procoagulants or the things that cause clots I've got here in the green circles, and that would be equivalent to stepping on the gas. They make clotting go. On the other hand, the brake pedals would be the red circles, and that's slowing down clot formation. They're putting the brakes on. Those are the anticoagulants. So again, factor 8, factor 9 are over here pushing on the gas, and protein C, protein S, TFPI, and antithrombin are over here stepping on the brakes to keep the system in balance. But what happens if you're born without enough factor? What if you have hemophilia and don't make enough of the green circles to cause the car to go? We're in imbalance and you have a tendency to bleed. Clotting happens too slowly. You have too much on the brakes. We can step on the gas more to speed the car up. That would be the equivalent of adding factor back to the system and put us back in balance. But alternatively, we can also ease off the brakes and do less of the braking, which would involve removing those anticoagulants. And that's what we mean by the rebalancing therapies. Rather than replacing the green circles, we're taking away some of the red circles. So the two targets that are under most active investigation, or drugs that are most that are closest to potential use in the clinic, are targeting antithrombin, one of those anticoagulants, and TFPI, one of the other ones. So these are the red circles again. The two drugs that we'll mention today are fitusiran, which is an antithrombin therapy, and Emicizumab, which is a TFPI inhibitor medication. So again, because this is rebalancing and isn't dependent on which specific factor you're trying to replace, it works for both hemophilia A and B. And because it doesn't look like factor 8 or 9, it can work for those with or without inhibitors. These drugs are also given as an injection under the skin. The dosing varies depending on which medication you're talking about. One of them is daily, the other one can be given monthly. Again, much like the mimetics, bleeding is treated with factor 8, factor 9, or a bypass agent, depending on your situation. And you cannot use fitusiran or Emicizumab to treat acute bleeding. There is, in theory, you could use these rebalancing therapies to treat other bleeding disorders as well, like von Willebrand disease or other bleeding conditions. That has not yet been investigated as far as I'm aware. Certainly talked about. So again, these are moving forward. Both fitusiran and Emicizumab are currently in clinical trials. There were some early concerns about blood clots for fitusiran, leading to some adjustments of the doses that were used for the clinical trials. We are awaiting results of the fitusiran phase 3 trial. Hopefully we'll hear about those very soon so that we can learn more about whether the drug works and is effective at that new dosing regimen, and again, learn more about safety. So those efforts are moving forward and likely to be in the bleeding disorders news in the next several months. Certainly, we're hoping to learn more and more as we go forward. So let's take a trip back again to hemophilia A with inhibitors. And the reason for that is that the next topic, gene therapy, at this point applies to only hemophilia A with inhibitors. Hemophilia B is still something that has not yet been done in hemophilia B. Gene therapy for people with inhibitors has not been done in humans, but we'll mention it animal studies at the end here in a little bit. So the main things to know about gene therapy is that the whole point is to replace the defective or missing gene, so the body will begin to make that factor again, either factor 8 or factor 9. There are two approaches to that, two kind of general ways this is done, and we use the Latin terms in vivo and ex vivo, which mean in the body and outside the body. And that really refers to where is the gene transfer taking place. So in vivo therapies, the vector takes the gene to the cells while they're in the body. We give those medicines by an infusion through an IV, and that applies to all, for example, all the AAV vector-based therapies. I'll show you a list of that in a minute. Outside the body, in those approaches, we take out the target cells from the body, they're modified, the gene is put into them, and then those cells are put back in, and those cells are the ones that make the new gene product, either factor 8 or factor 9. And again, we'll mention that as we go forward. So this is just an overview of that ex vivo gene therapy approach that I just went over. This approach is used in different, gene therapy is used in different types of blood and other disorders. So examples would be thalassemia and sickle cell, which have been treated with an ex vivo approach. In vivo has been used for some other genetic disorders, but also hemophilia A and B. Speaking of, this is a partial list now of gene therapy clinical trials, and all of these are you can look up on clinicaltrials.gov and see public updates of what's happening with these different studies. There's factor 8 studies listed here on the left. There's factor 9 gene therapy studies listed on the right. One of these, the Unicure factor 9 gene therapy for people who do not have inhibitors, is further along in their trials. They've finished their phase 3 trial. Again, we're waiting for final results from that study. We'll highlight these three here. So there are two companies doing factor 8 gene therapy for people with inhibitors, and then another that's doing, those are both in vivo AAV approaches, and then there's an ex vivo study which we'll mention. Let's skip these slides given time. So for the two trials doing the in vivo gene transfer, these are essentially the same or similar products that are being used in patients who do not have inhibitors. And those trials have been going on for several years now for those without inhibitors. But the idea is that after the body begins making the gene product, either factor 8 or factor 9, in this case it's all factor 8, that continuous exposure may induce tolerance, just like ITI is supposed to. And the hope is that the inhibitor would then go away as the body becomes tolerant of factor again. This has been successful in animal studies, even in hemophilia B, but there are no studies with hemophilia B with inhibitors in people yet, and that's partly due to the more complicated nature of having an inhibitor to factor 9 and other complications like an allergic reaction that can develop when people with factor 9 inhibitors get factor 9. So that makes things more complicated. There is a third trial that that I mentioned that's an ex vivo approach to gene transfer for factor 8. And in this one, the investigators are taking out platelets, the cells that make platelets in the body, putting the factor 8 gene into those cells, giving them back to the person, and then they make platelets that have factor 8 in them. And that actually happens normally. If you don't have hemophilia A, your platelets have factor 8 in them. And so they're basically putting it back where it goes. And the platelets carry around the factor. And the idea is that the inhibitor can't get the factor when it's in the platelet, and so it can be taken to where it's needed and do its job. And so I think of that as like a chaperone, or more as like a bodyguard, where the platelet is carrying around the factor to where it needs to go, letting it do its job and protecting it from the inhibitor. You might have concluded, if this is how you're now making factor, you won't detect factor levels in the blood. They're just in the platelet. But this is an ongoing study, and we're also all hoping to hear some results from this over the next. These trials will take years to kind of complete, but they are open and recruiting, looking for potential people to participate. Which I just have written here. You can find them on clinicaltrials.gov. Easy enough to search for hemophilia A with inhibitors and gene therapy, and they will pop up. So just as a recap of what we talked about, the new approaches to bleeding prevention in people with inhibitors, there's the factor VIII Mimetics, one of which has been on the market now for about 4 years, Emicizumab, and some others that may be reaching that point in the near future, including the rebalancing therapies that we talked about, and possibly second generation factor VIII Mimetics. And also a lot of hope that gene therapy will offer an effective way to both prevent bleeding by making factor levels come up to a sustained level, and also eradicate inhibitors through immune tolerance. We hope and expect that there will be many advances yet to come, but this is where I see that we are right now.
Wonderful. Thank you so much, Dr. Buckner. That was amazing. Thank you for all that information. We are going to move into a Q&A session. We have a couple minutes here for Q&A, so if you haven't already put some questions in the chat, please do so. If you haven't clicked on that Q&A button at the bottom of your screen and put a question in there, now is your time to do that. And we have a first question here. You talked a little bit already about this in your presentation, but could you talk a little bit more about doing ITT while on Emicizumab? Are there any trials or studies on that?
Yeah, that's a great question. And as I briefly mentioned, there are studies investigating a few different approaches in terms of the regimen. And what we don't know, because we don't have anything to compare it to, is whether giving lower doses less often will be enough to induce tolerance. And really, a lot of the reason for wanting to do that is to remove some of the burden of ITI, which is really, really tough. It often, in a child especially, requires putting in either a port or a central line so that you can do the IV infusions every day. The idea of giving Emi, and the reason why that is potentially helpful, is that it really controls bleeding while you're waiting for that inhibitor to go away. Part of the rush without Emicizumab is, how do we control bleeding and prevent bleeding as much as we can, and getting inhibitors to go away quickly mattered a lot more before Emicizumab was around, is how I think of this. As many bleeds as you can prevent will help down the line with preventing joint damage and other problems that can come with repeated bleeds. And so that is being investigated in at least a couple of trials I'm aware of, with regimens, ranging from every other day low dose treatment, 3 times a week low dose treatment, to really see if they're as effective and how well people do taking those approaches.
Great, thank you for that. We have some more questions coming in. what is coming for non-AAV vectors for gene therapy?
Oh goodness, that's a very astute question. The honest answer is I haven't heard a ton related to some of the different non-AAV vectors. It's a super important question because many people already have immunity to this vector. So by vector, what we mean is virus that's been modified so that it no longer acts like a virus, but more like a package delivery system, or vector for short. That being said, even though it doesn't act like a virus in all ways, it does still look like a virus. So people who've been exposed to those viruses in the past, which AAV is something that, you know, a third to half of us already have antibodies to AAV, those may not be as effective in people with that immunity. And so there's a lot of interest in other approaches, including using other types of virus like lentiviral vectors, which have been one of the main approaches to gene therapy that's not AAV based. The ex vivo approaches aren't affected in the same way because the body's immune system is not there when the gene transfer occurs. And so that's only applicable in general to the in vivo approaches. But I would say that the lentiviral vectors have been investigated. There are other vectors that are similar to AAV but have been modified in some way that are also ongoing, but they are in many ways similar to AAV.
Okay, thank you. We are running out of time a little bit, but I think we have a time for maybe one or two more questions. Are you at all concerned with those going on Emmy as infants that inhibitors may form later once factor is needed?
Again, everyone who's asking questions is asking the right ones, very astutely asked. We don't know. We don't fully. Inhibitors are a huge challenge for the people who live with them and for the people who try to figure out why they happen and how to make them go away and how to prevent them, because the immune system is incredibly complex. And one of the big questions is, you know, since we know that the vast majority in someone with severe hemophilia, the vast majority of inhibitors will develop in the first 50 and really even in the first 20 exposures to factor VIII. So if they're going to happen, they usually happen early. What we don't know is if we delay those factor exposures to when the immune system has kind of grown up and started acting more like an adult immune system, will that be a situation where we're less likely to see inhibitors develop? And we don't know. Those studies, yes, those questions are being asked by study. I believe Haven, I might misspeak here, but I believe Haven 7 is a study looking at that question of using Emicizumab from early in life and perhaps delaying the need for factor VIII. You know, somebody might not get their first 20 doses for years. And so we don't know if that's only delaying an inevitable inhibitor development in someone who just is predisposed because of their immune system to getting an inhibitor or not. And those are certainly hot questions that will continue to be, you know, watching for answers. A study like that is going to take a long time, because if you know you're having to watch somebody for years and years, that is something that takes time to understand. But that is also a good thing, because it means that they're not having bleeding. So I know I've gone over.
It's okay. No, this is wonderful. I hate to cut you off. We have so many questions coming in, but we're like super out of time. So If you could go to the next slide, that would be great. And I will close this out really, really quickly. Again, thank you everyone who is coming. Thank you everyone who wrote in a question. I know we didn't get to all of them, so I did put in the chat the inhibitors@hemophilia.org. And maybe if you can ask your question there, we can get those questions to Dr. Buckner and get those answered after the session if he's willing. But again, thank you for coming. Thank you, Dr. Buckner, for giving an incredibly wonderful and informative presentation. We're very grateful for the information you shared with us today. Thank you all for coming again. Your feedback does matter to us to help us plan a better BDC in 2022. If you complete this evaluation, you will be entered into a raffle for a $75 gift card. Raffle winners are selected Thursday, Friday, Saturday, and we will email the winners. And with that, again, thank you all for coming. We appreciate it. I hope you have a wonderful rest of the conference. Thank you.
Thanks, everybody.